Hello, everyone. So, welcome to the new chapter, and here are the learning objectives for the lecture on tumor markers. Define key tumor-related terminology, including tumor, neoplasm, benign, and malignant tumors, cancer, aplasia, carcinoma, adenoma, and explain their clinical significance. For instance, a benign tumor like a lipoma grows slowly and doesn't spread, while malignant carcinoma can invade surrounding tissues and metastasize to distant organs. So we will be able to define those key tumor-related terminology, explain concept tumor markers, including their definition, biological sources, and their roles in detection and monitoring of malignancies. Describe the desirable characteristic of a ideal tumor marker, including specificity, sensitivity, correlation with tumor burden, prognostic value, and assay-related requirements. So this objective focus on understanding on what make a tumor marker clinically significant or useful. Identify the major clinical applicants of tumor markers, such as their use in screening, diagnosis, staging, monitoring, treatment response, detecting recurrence, and assessing prognosis. For example, we will learn about prostate-specific antigen, which is used for prostate cancer screening in men, while CA 125 helps monitor ovarian cancer treatment response and detect recurrence. Classify tumor markers by type, including enzymes, hormones, receptors, proteins, genetic markers, and other related to relevant cancer. We discussed the clinical relevance, strengths, and limitations of specific tumor markers, including CEA, PSA, HGG, SCG, AFP, CA 15-3, CA 125, CA 19-9, in terms of their diagnostic and monitorings. So, in other words, we will learn the most commonly used tumor markers in clinical practice, interpreted laboratory factors, and pre-analytical considerations that affect tumor marker reliability, such as sample handling, storage condition, assays variability. So first of all, it would be the definitions of either tumor or neoplasm. That means that a tumor is essentially a mass of cells that have lost their normal growth control. Benign tumor are those tumors that remain confined to its primary size. A benign tumor is like a well-behaved one. It stays where it belongs and doesn't cause trouble anywhere. Malignant tumor are those that causing the problem. It's capable of invading surrounding normal tissues and spreading, metastasizing through the circulatory and lymphatic system to distant body size. So we call it cancer. Cancer is a malignant neoplasm tumor. So we can use the term cancer or a malignant tumor as the essentially synonyms. So when we say someone has cancer, we are actually specifically referring to a neoplasm with dangerous characteristics of invasion and potential metastasizing. Tumor markers are the substances that we use in the laboratory where we detect the synthesis by the tumor and also by the host in response to a tumor that can be used to detect the presence of tumor. That means the tumor markers are measurable substances that serve as the indicator of cancers. Anaplasia refers to the loss of cell differentiation and change in cells and tissue structure from typical or normal. Normal cells are highly specialized. For example, a liver cells looks and functions very differently from a muscle cells, But in the anaplastic tumor, the cells lose their specialized characteristic and begin to look primitive and disorganized. These cells are usually resemble their tissue of origin and often appear very bizarre under the microscope. Carcinoma is a malignant growth arising from skin or organ tissue epithelium. So this is definitely the most common type of cancer. The epithelial cells, epithelial tissues forms the lining of organs and outer layer of skin, right? So carcinomas develop from the surface of lining tissues. Adenoma is a benign growth arising from granular epithelium. So adenoma is a benign counterpart of your carcinoma, but specifically from granular tissues. While adenoma are benign, some actually can transform to malignant adenocarcinomas over time if it's not being detected early. So that's the reason why we have to really learn how to realize what make a ideal tumor marker for clinical uses. Specific for cancer, that means the marker should only be elevated in the presence of cancer, not in benign conditions or normal physiological states. Always present with tumor. Amount of marker produced should correlate it well with the tumor load. There should be a direct relationship between the level of the marker and the amount of cancer in the body. The half-life of the marker should be short, so serum levels must drop, producing undetectable concentration when the patient is in remission. The characteristics ensures that the marker quickly disappears from the bloodstream when the cancer is successfully treated. So half-life refers to how long it takes for half of the substance to be cleared from the body. A short half-life means that the treatment eliminated cancers. The marker levels will drop rapidly to undetectable level, confirming that the patient is in remission. Levels of markers should have prognostic value. So higher levels might indicate a more aggressive disease or poorer survival prospects, while lower levels might suggest better outcome. So here are some of the desirable characteristics that focus on clinical application and laboratory aspect of tumor markers. Screening cells identify individuals in early stages of disease in the asymptomatic population. This means that an ideal tumor marker should be able to detect cancer before the patient develops symptom or feeling sick. Screening tests should have a high diagnostic sensitivity. That is, the test should have a low rate of false negative results. This explains a good screening test must be highly sensitive and it correctly identifies most people who actually have the disease. Confirmatory tests to positive screening test should have a high diagnostic specificity. That is, the test should have a low rate of false positive. The confirmatory test must be highly specific, meaning is correctly identify who truly has cancer versus who doesn't. A false positive result occurs when the test say cancers, but no cancer is actually present. Assays for the marker should be analytically sensitive, specific, accurate, precise, easy to perform, inexpensive, and rapid. The assays must be analytically sensitive, which able to detect very low concentration of marker. Specific meaning it doesn't cross or doesn't cross react with similar substances. Screenings for the disease. So that's just one of the use of the tumor marker is also the diagnostic for symptomatic patient and support in clinical staging. So it's referred to using tumor marker levels to develop to help determine how advanced the cancer is at the time of diagnosis. Measure of tumor burden. So higher markers level generally correspond to larger tumor mass or intensive disease. Monitoring response to therapy. So now, for example, if you have a CEA level continue to rise during chemotherapy for colorectal cancer, so CEA is the one for detected for colorectal cancer. So if the CEA level is high, continue to rise during chemotherapy, so the oncologist might switch to different chemotherapy regimen. So that is the one that we um, monitoring the response to therapy, detecting recurrence of disease and prognostic indicators. So the prognostic information help the physician guide treatment intensively and also for discussion with the family for the expected outcome, etc. So here is what you need to know about the CEA, embryonic antigens. So one of the most widely used tumor marker. They belong to family of glycoprotein. So the CEA is a protein that has a carbohydrate sugar group attached to it. It's elevated in colon cancer, lung cancer, gastric, breast, pancreatic cancer, ovarian cancer, uterine cancer, and prostate cancer. So the CEA can be elevated in so many levels of cancer types. And as you see here, there's a whole bunch of them here. So that means is also um, increase in some benign conditions like inflammatory bowel disease, liver disease, and even in heavy smokers. It's not specific enough to determine what type of cancer specifically a patient might have, based solely on the elevated CAA level. Problems with the CA problem with using CA as a marker is elevated in non-malignant conditions, as we talked about. Now we have others that also increase in non-malignant conditions such as pulmonary emphysema, acute ulcerative colitis, alcohol, cirrhosis, inflammation, or bowel disease, cystic fibrosis. This create a major problem because elevated CEA doesn't necessarily mean the cancer is present. It could simply reflect one of these non-cancerous condition. Not specific, therefore has diagnostic utility. This emphasizes that the CEA can be elevated in so many different conditions, both cancerous and non-cancerous. It cannot be used to diagnose cancer. It's most useful in established prognosis and monitoring therapy and recurrence of disease. This describes the CEA true clinical value. Once a patient have been diagnosed for cancer through the other means, for example, biopsy, imaging, and clinical examination, CEA is become a very useful for several purposes. So that means we need to couple with other treatment, other diagnostic tool that you employ in the hospital. Now we are going to discuss the specific cancer marker. The first one is prostate specific antigen, PSA. Serine protease produced exclusively by the epithelial cell in the prostate. And PSA is an enzyme that breaks down the protein that is made only by the cells that line the prostate gland. PSA is the only tissue-specific marker identified so far, but it is not specific for prostate cancer, found in small amount of normal prostate, also elevated in benign prostatic hyperplasia. So, and the enlarged prostate, benign prostatic hyperplasia, is a common benign condition in older men when the prostate grows larger, producing more PSA without any cancer being present. This means the elevated PSA could indicate cancer, but also could simply mean the prostate is enlarged due to normal aging. Only tumor markers approved for screening for prostate cancer is useful in diagnostic tool. It highlights why PSA is really unique among the tumor markers. Despite its limitations, PSA is the only tumor markers that medical authorities have approved for population screening in apparently healthy men. However, PSA screening remains somewhat controversial because it actually can lead to the overdiagnosis and overtreatment of slow-growing cancers that might never cause harm. Useful in detecting, staging, and monitoring disease. For example, PSA helps detect prostate cancer when elevated level prompt further investigations like prostate biopsy. Serum PSA is roughly proportional to volume and should return to normal within 1 month on prostatectomy. So there is a relationship between the PSA level and the amount of prostate tissues present. Larger tumor generally produce higher PSA level. So after complete surgical removal of prostate, PSA should become undetectable within a month because there's no longer any prostate tissue to produce it. So that is the expectation. Now, here are the important technical details about the PSA testing that affects the clinical interpretation. PSA exists in both free and complex. So PSA complex is 2 alpha 1 anti-chymotrypsin formed in serum. PSA circulate, that means that PSA circulate in blood into different form. The some free floating in the bloodstream, while other bound to a protein called alpha 1 anti-chymotrypsin, forming a complex. Immunoassays are available for total, free, and complex PSA. Percent of free and total PSA and percent of complex total PSA are used to differentiate between the prostate cancer and the BPH, benign prostate hyperplasia. So this explained on how the ratio between different PSA forms help distinguish between cancer and benign prostate enlargement. So for example, if a man has a total PSA of 6 nanogram of milliliter, but only 10% is free PSA, what does that mean? It suggests a higher likelihood of cancer compared to a man with the same total PSA, which is 10%, but 25% of free PSA. So this ratio analysis helped reduce unnecessary biopsies in men whose elevated PSA is more likely due to the enlarged hyperplasia, enlarged prostate gland rather than cancer. It is imperative that the same assays be consistent, used to monitor PSA values for a patient due to a different cutoff for different assays. So that imply to different hospital laboratory have a different cutoff. So it's important that the same assays must be used to monitor the PSA. So next, here's what you need to know about the HCG, human chorionic gonadotropin pregnancy hormone. It's normally secreted by the syncytial cells of placenta. D-dimer compose an alpha beta subunit. Alpha subunit is found in FSH, LH, and TSH. Beta subunit is specific to HCG. So HCG structure consists of two protein chains linked together, the alpha and beta subunit. The alpha subunit is actually shared with other important hormones like stimulating hormone, FSH, LH, luteinizing hormone, TSA, thyroid stimulating hormone. However, the beta unit is unique to SCG, which is why pregnancy tests and tumor markers assay specifically measure the beta subunit to ensure accuracy and avoid cross reaction with other hormones. STG is commonly measured to confirm pregnancies, but also extensively used to monitor trophoblastic pathologies, and germ cell tumor of testes and ovaries. This explains the STG's two roles in clinical medication. In medicine, most people are familiar STG as hormone detected in home pregnancy tests. However, HCG also serve as crucial tumor marker for specific type of cancer. For example, trophoblastic pathologies like molar pregnancies, so the abnormal placental development, so those kind of thing. And actually, in men, the germ cells tumor arise from reproductive cells and it can occur in both men and women. In men, these include testicular cancers like semi-non semi-to cells tumors. So if it's increased in men, it might be suggesting the testicular cancer as well. Alpha fetoprotein, another important fetal antigens that used in both prenatal screening tool and turbo marker, is synthesized in yolk sacs, fetal liver, GI tract, and kidney. Is structurally related to albumin. In other words, AFP has similar protein structure to albumin, which is a major protein found in blood plasma. So this structural similarity reflect their origin and similar function. Both proteins help transport substances in blood and maintain proper fluid balance. It's used as a marker for neural tube defects and screening tool for Down syndrome. Neural tube defects like spina bifida, which is an incomplete closure of spinal cord, caused to AFP leaked from the fetus to mother bloodstream and resulting in elevated maternal AFP level, and that's how we measure them. So in conversely, Down syndrome is associated with lower than normal maternal AFP level. That is how we detected the patient might be prone to Down syndrome. Moderate elevation in liver disease, such as hepatitis, cirrhosis, AFP level differentiate benign from malignant condition. So patients with hepatitis and cirrhosis might have AFP level that are moderately elevated, while patients with liver cancer typically have much higher AFP levels. Cancer antigen 15-3, CA15-3, is another important tumor marker primarily associated with breast cancer. They are a type of glycoprotein present on mammary epithelium. It's increased in breast cancer, but not specific. Increase in variety of carcinoma, such as pancreatic lung, ovarian, and colorectal and liver. So this lack of specificity means that elevated CA15-3 level cannot be used to diagnose breast cancer alone or distinguish breast cancer from other types of malignancies. It's used to monitor patient after surgery, for example, breast cancer after their initial treatment, used in combination with CA2729, which is the FDA approved for monitoring recurrence and other breast cancer markers. CA125 is a glycoprotein defined by monoclonal antibody OC125. OC stands for ovarian cancer, reflecting where the marker is first identified, ovarian. It is a good marker for ovarian cancer, but again, it's not specific. It's not exclusive to ovarian cancer. It also be elevated in other cancers such as the pancreatic cancer, fallopian tubes cancers, um, liver disease, etc. Limited use in diagnosis, but useful in conjunction with CEA. So the CA125 alone is not sufficient in diagnosing ovarian cancer because it's potential to false positive. But when it's used together with other marker like CEA, it can provide a comprehensive information. It's useful in monitoring disease in ovarian cancer patient. Once patient has developed or diagnosis with the ovarian cancers, through other methods such as biopsy, surgery, or imaging, CA125 become a very excellent tool for tracking treatment response and detecting the reoccurrence. CA 119.9 is a blood group antigen. So interestingly, people who lack of certain blood group genes, particularly who are Lewis antigen negative, which include about 5 to 10% of population, cannot produce CA19-9 at all. So if you are lucky, if you have no Lewis antigen on your blood at all. So it's specific for pancreatic cancer, but also present in other gastrointestinal cancer. It may also be increased in disease associated with biliary tract obstruction and cystic fibrosis. It used to monitor therapy and predict reoccurrence. So, for example, if the patient who undergoes successful pancreatic cancer surgery should sees their CA 19.9 levels drop, if their level begin rising, follow up during the follow-up visit, that alert the doctor to investigate for possible cancer reoccurrence. Enzyme isoenzyme at tumor markers. So prostatic acid phosphatase, a PAP, is used as a tumor marker for prostate cancer. While PSA, as we talked about, has largely replaced uh, PAP as a primary prostate cancer marker due to better sensitivity and specificity, the prostatic acid phosphatase can still provide valuable information, particularly in monitoring advanced prostate cancer. CKBB is another enzyme isoenzyme that used as tumor marker for prostate and stomach cancer. Creatinine ki crack creatine kinase BB is specific form of creatine kinase enzyme that can be elevated in certain cancers. Creatine kinase normally function in energy for metabolism in cells, right? But BB isoform brain type can be inappropriately produced by cancer cells in the prostate and stomach. So that's why it can be CKBB can be used as a tumor marker for prostate and stomach cancer. ALP, alkaline phosphatase, is used as tumor marker of bone and liver. For example, if the breast or prostate cancers that spread to bones often cause elevated ALP levels due to increased bone turnover at metastasis. Similarly, liver metastasized from various primary cancer can cause ALP elevation as cancer disrupt normal liver function. Amylase lipase are tumor markers for pancreatic cancer. So it means that these digestive enzymes, which are normally produced by pancreas to break down starch and fat respectively, can elevate it in pancreatic cancer. Okay, so now we are going to switch gears to cardio biomarker testing. So it's all about the heart. The goal of for the key management goals for cardiac patient is acute diagnosis, effective risk stratification, and target of therapy, and anti-thrombotic and anti-platelet therapy in halting the propagation or recurrence of coronary thrombosis. So it tells us that use of blood thinning medication to prevent or treat blood clots in coronary arteries. Antithrombotic drugs like the heparin prevent platelets from sticking together to form clot. So the goal is to stop existing clots from growing larger. Interventional treatment with cardiac catheterization. So it's a minimally invasive procedure performed through cardiac catheterization where thin tubes are inserting into the blood vessel to reach the heart. So these target interventions can quickly restore circulation and prevent further heart damage. The classic symptoms are intense, oppressive excruciating chest pressure. That is one of the symptoms of the acute myocardial infarction. So if the patient come in at the hospital with AMI, acute myocardial infarction, you would see them presenting with these kind of symptoms: intense, oppressive, excruciating chest pressure. A patient also described it as a impending sense of doom, and referring to overwhelming feeling that something terrible is happening. Other symptoms might include chest heaviness or burning, radiation to other areas, indigestion, vomiting, nausea, and diaphoresis. In other words, heart attack symptoms can be quite variable and don't always present at the classic chest pain. Differential diagnosis is broad and symptoms are variable, still making this a complex diagnosis, commonly in emergency department. This explains why diagnostic heart attacks can be challenging for emergency physician. Acute coronary syndrome. So acute coronary syndrome is not a single disease, but rather an umbrella term for several related conditions that all result from decreased blood supply to the heart muscle. Is happen in asymptomatic patient. Is stable angina. That means a chest pain or discomfort that occur predictably with physical exertion or emotional stress and is usually relieved by rest or some sort of medication. Unstable angina is the chest pain that has recently changed in pattern, becoming more frequent, severe, or occurring at rest or with minimal exertion. Acute myocardial infarction is representing the actual death of heart muscle tissues due to complete or near complete blockage of coronary artery. So here is a diagram that's showing the ECG waveform, which we can see the characteristic of ST elevation, highlighted in yellow here. This demonstrates how the normal flat ST segment between the S and T wave elevated above baseline during the certain type of heart attack. So each, ECG change depend on the location and severity of myocardial necrosis. Virtually 100% of patients with characteristic Q wave or ST segment changes are diagnostic with myocardial infarction, meaning 100% specificity. When the patient develop classic ECG pattern of normal Q waves and ST segment elevation, this virtually diagnostic of heart attack. However, as many as 20 to 30% of myocardial infarction do not produce characteristic ECG change. Sensitivity detect MI is between 50 to 70%. While ECG is highly specific for when abnormal, it has relatively poor sensitivity, meaning it can miss a significant number of actual heart attack. So up to 30% of patients have genuine myocardial infarction may have normal or non-diagnostic ECG, especially early in the course of the heart attack or with a certain type of heart attack. This is why cardiac biomarkers like troponin are so important, which we will learn in a little bit. They can detect heart attack and ECG might have missed. ECG may be insensitive for detecting prognostically significant ischemia. So in another word, the silent ischemia can still very dangerous and may require treatment. That ECG might not be able to detect the important heart muscle oxygen deprivation that could lead to serious complication or poor outcomes. So this is another way of the imaging or the ECG changes that occur during different type of acute coronary syndrome. So it is a normal ECG at the top here, then progresses to STEMI, showing the ST elevation, then NS STEMI, showing the ST depression, and then the T inversion. So the cardiac enzyme are usually the AST, LDH, and CK. So these are the traditional laboratory tests that historically used to diagnose heart attack. These enzymes leaked out of damaged heart tissues into the bloodstream where it can be measured. It's distinguished from ALT, which is alanine aminotransferase related to liver cancer. It means it's important to not confuse AST with ALT because ALT is primarily a liver enzyme. ALT, formerly called SGPT, is more specific to liver damage, while AST can come from both heart and liver tissues. ASTs is the stand for aspartate aminotransferase. In other words, AST is an enzyme found in heart muscle, liver, and other tissues that become elevated when tissues are damaged. When heart muscles dies during the myocardial infarction, AST leaks into the bloodstream and can be detected by laboratory testing. LDH, lactic dehydrogenase. So, lactic dehydrogenase is particularly useful in the past for detecting heart attacks that occurred several days earlier, as it remains elevated longer than some other markers. CK, creatine kinase, it involved in energy metabolism within the muscle cells, included heart muscle. When heart muscle is damaged during myocardial infarction, CK is released in the bloodstream. However, remember, CK is also found in skeletal muscle and brain tissues. So elevations can occur from non-cardiac causes like muscle injury from exercise or surgery. CK. All right, so we talked a lot about CK, but now it's dive deep a little bit into levels of CK that are often not helpful in initial diagnosis, since it takes at least 6 hours for there to be an enzyme leaked into tissues, into the bloodstream from the onset. Enzyme should be reassessed every 8 hours for the first 24 hours because CK level rise and fall in a predictable pattern after heart muscle damage. So that's why a serial testing at regular interval help track the progression and confirm the diagnosis. Enzyme is helpful in gauging the size of MI. So the CK isoenzyme, we use the agarose gel electrophoresis in fluorescence detection. Now we have the three different type of CK, CK3, CK2, and CK1 is CK3 for skeletal muscle, CK2 for heart muscle, and CK1 is for the brain. Creatine kinase is an enzyme found primarily in your skeletal muscle, heart, and brain. It plays a crucial role in, again, in the muscle function by helping to produce energy. It helps convert the creatine into phosphorus creatine, a high energy molecules that muscle use for quick burst of energy. So, as previously discussed, we have the three types of CK enzyme. CKMM found mostly in skeletal muscle, CKMB found mostly in heart muscle, and the one that found mostly in brain tissue is CKBB. Testing. The CK test measure the amount of this enzyme in your blood. Elevated level can indicate muscle damage, which might be due to intense exercise, muscle disease like muscular dystrophy or heart conditions such as heart attack. So it emphasized that CKMB is a heart-specific isoenzyme that makes CK useful for cardiac diagnosis, but also noting that total CK can be elevated by non-cardiac causes. How about the measurement? We can do the electrophoresis, but not use anymore. It's really labor intense. Now we are looking into immunoinhibition or precipitation, antibody to M subunit multiply result by 2, interference by from CK1, which is a BB. Now, the evolution of laboratory methods for measuring CK and MB has intensively discussed in many literature. Modern immunoassays are more specific and accurate than older method, measuring the actual amount of CK and B protein rather than just enzymatic activity, providing more reliable indicator of the heart muscle damage. AST is found in liver, heart, and now more commonly measured as liver enzyme. It increase in AMI, but not very specific. The normal ratio is LD1 is less than LD2, LD5 less than LD4. This describes the typical pattern of LDH isoenzyme in healthy individuals. In normal circumstances, the LD2 levels are higher than LD1. The LD3, LD4 levels are higher than LD5. These normal ratios serve as a baseline for detecting abnormal pattern that can suggest a tissue damage. If LD1 greater than LD2, it suggests the myocardial infarction, but also suggests hemolytic anemia, pernicious anemia. Um, so that means it's limit its cardiac specificity, right? LD5 is greater than LD4 is indication of liver disease. When LD5 levels exceed the LD4 levels, it typically indicates liver damage or disease since LD5 is primarily found in liver and muscle tissue. A total LDH measure from of 5 isoenzyme. So for the purpose of this, do not worry about the percentage. Just remember the total LD is a measure of 5 different isoenzyme. Other biomarkers, cardiovascular disease, less commonly requested. So we explore different ones: C-reactive protein, fibrinogen, lipoprotein A, and homocysteine. The C-reactive protein is the commonly used test in evaluation of inflammatory processes, arthritis, and autoimmune disease. C-reactive protein is also found to be expressed in atherosclerotic plaque, which is a clot in your artery, may enhance expression or adhesion molecule after the LDL cholesterol uptake by macrophages. It is a high sensitive method with detection limit of 0.2 net milligram per liter allow the differentiation of low-level inflammatory implication of coronary artery disease. Fibrinogen is a large glycoprotein, the final step of coagulation cascade. Fibrinogen is essential for the coagulation, the body ability to stop bleeding. The normal levels are usually from 200 to 400 milligram per deciliter, and the fibrinogen tend to rise along with other cardiovascular risk factors. So high LDL, bad cholesterol, is associated with the high fibrinogen level, while high HDL, which is the good cholesterol, is associated with the lower fibrinogen level. Recent studies show that elevated fibrinogen is associated with 1.5-fold increase in risk of developing myocardial infarction. Lipoprotein A is the one that we will be to discuss next. It consists of LDL particle containing the apolipoprotein B100 molecule and apolipoprotein A molecule. The plasma concentration is from to 100 milligram per deciliter, but most values are less than 200 milligram per deciliter. So lipoprotein A is persistently high, will promote the development of the atherosclerotic plaques in arteries. Recent studies show that asymptomatic individual with high level has a risk of the coronary artery disease, usually have a 70% higher risk. Homocysteine is the amino acid formed in as a byproduct of metabolism of essential amino acid methionine. In 1970, inborn errors metabolism result very high level in homocysteine. So prospective studies show homocysteine is associated with cardiovascular events, and these observations is a link was established in between moderate levels and atherosclerosis. Um, while elevated homocysteine is associated with increased cardiovascular risk, attempts to reduce cardiovascular events by lowering homocysteine with vitamin have not consistently shown benefit, making it clinical utility very uncertain. Myoglobin is another one, is an early but non-specific biomarker. It rises quickly after heart attack, but also after many muscle injury. It's mainly useful to rule out heart attack when it's normal. So it is an intracellular heme protein that supports the transportation of your oxygen. Myoglobin is abundant in both cardiac and skeletal muscle. And the important thing here that you really need to remember is elevated occur or detect within 1 to 4 hours after symptoms and return to normal after 12 hours. Now we are discussing the most important one in the this chapter, which is the troponin complex. Troponin is a contraction regulating protein found in the thin filaments of the muscle, and it is composed with the three non-identical subunit. You have the troponin has become the most sensitive and specific test for myocardial damage. Troponin C is a calcium-sensitive subunit but contains four calcium binding site. Troponin I, an inhibitory subunit binding acting in the relaxed state, and troponin T bind to tropomyosin and acting. This introduced troponins as the current gold standard for diagnosing heart attacks. Troponin is a regulatory protein complex that controls muscle contraction. And when heart muscle cells die, troponin is released to the bloodstream where it can be detected with exceptional sensitivity and specificity. So these subunits, troponin C, I, and T, work together to regulate when heart muscle contracts based on the calcium availability. Troponin T and I. So they are the protein found in the thin filament of the muscle. It has the early release due to the cytosolic pull. In other words, the heart muscle cells are damaged. There in immediate release of troponin from the free floating pool within the cell cytoplasm. Sustained release due to myofibrils is a prolonged elevation of the protein level that occurs as structural component of muscle fibers, which is the myofibrils, break down over days following the heart muscle damage. Cardiac troponin is not released from skeletal muscle, and that's why it gives us the key advantage for cardiac troponin. They are heart specific and are not released when skeletal muscle are injured. That's why it has a very high tissue content. So which troponin? Troponin I is specific for cardiac muscle. It's usually rise about 3 to 3 to 6 hours post myocardial post MI, peaks at 14 to 20 hours and remain elevated 5 to 10 days. Studies show its utility in risk stratification. Then the troponin I is a clinical characteristic and explain why it's preferred in patients with kidney disease. Troponin T is also specific for cardiac muscle. It rise 3 to 4 hours post MI and peaks about 10 to 24 hours and remain elevated for 10 to 14 days. And that's why troponin T has been shown to be a useful risk stratification and in detecting perioperative myo during procedures. It may also be elevated in renal disease. So this explains why troponin T has similar cardiac specificity, but can elevate it in the kidney disease, even without heart damage, which is why troponin I is often preferred in renal patients. Now, let's look at CTNT and CTNI with the graph. This graph shows the different cardiac biomarkers rise, falls over time after a heart attack, with both T and I showing the highest peaks at most prolonged elevation compared to older markers such as CKMB and myoglobin. The CT is slightly larger than CT and I and remain positive after AMI longer. So lastly, we will discuss the BNP and anti-proBNP. So this introduced the BNP as a different type of cardiac marker rather than indicating heart muscle damage like troponin. So it stands for beta natriuretic peptide. It helps diagnose the presence and severity of congestive heart failure. Brain natriuretic peptide are naturally occur peptide hormones synthesized in the brain, and the name brain natriuretic peptide is historical because it's actually produced primarily by the heart when the ventricle are stretched or under pressure. BNP and proBNP are increased in the patient with kidney disease.